sodium with regard to hyperglycemia. Now what happens is that when plasma glucose increases, then it is found that the sodium level goes down. So let me tell you a scenario. A 60-year-old male patient comes to A&E with drowsiness and the CT scan brain is showing subdural hematoma. So when the blood investigations are done, this patient is also a diabetic. The Rbs came out to be 800. And the sodium came out to be 119 milliequivalent. So here is a patient who is having a subdural hematoma. Along with the Rbs is very high and the sodium is high. So what could be the cause of this patient drowsiness now? Is it subdural hematoma? Yes, it can be. If there is a massive subdural hematoma. Rbs high? Yes, if it is associated with diabetic ketoacidosis. But the important point of this thing is that the 119 sodium can also be a cause of drowsiness, because as we know, hyponatremia is an important cause of altered sensory. But is it 119? Is there anything relation between sodium and Rbs? Yes, there is a relation. So let me first break it out. What happens? So what happens is that this is a cell of our body. This is a extracellular fluid. So what happens is that when Rbs increases in this, normally when Rbs increases, insulin helps to move the Rbs sugar from this compartment to this one. However, in case of diabetes mellitus, because either it is type 1 or type 2, the injection of insulin is not sufficient. So here we get a lot of active Rbs molecule in the blood. That's why when we draw the syringe, we get a lot of Rbs involved. Now, Rbs causes increase in the osmolarity. As we know, the osmolarity is active solid particles which are present in the blood. So because there is an increase in the osmolarity, serum osmolarity, it will draw water from the intercellular compartment to the extracellular compartment. So once you get the extracellular compartment, what happens is that the water gets here. In this situation, we also know that sodium is a major extracellular cation. So this will dilute the sodium, causing low sodium level. This is not true hyponatremia, but this is very low sodium. We will talk about hyponatremia in subsequent classes. So this causes a low sodium level. So it has been found that for every 100 milligram per deciliter increase of plasma glucose from normal, suppose blood glucose of 100, from 100 milligram, the sodium level decreases by, some book says 2 to 2.4 milli equivalent per. Now we have got some formulas. Formula is the corrected sodium is equal to the measured sodium which you get in the blood, which is 199. You have to add plus to this, and you have to give a correction factor 2.4, because every decrease 2.4. Open the bracket and you see the Rbs of the blood minus the 100 divided by 100. So this is the most common formula. Two formulas. Number one, sodium decreases by 2.4 every increase of blood goes from 100, from normal 100, and the formula here is corrected sodium is equal to measured sodium. Another formula many people use are corrected sodium is equal to measured sodium is in the blood plus 0.016 into the plasma Rbs minus 100. These two formulas. So let us see. In our patient, the patient had Rbs of 800. The sodium level was 190. So if you use a formula for every 100 increase from normal 100, it should rise by 2 to 2.4. Then suppose there is 2. So there is 100, 100, 200, 2, 300, 4, 400, 6, 600, 8, 800, 10. That means this patient potassium sodium has increased from 2, 4, 6, 8, 10. So if multiply this by, or you can do it like this, suppose it is increased to 8, 8 times your 2 is equal to 16. You put 119 plus 16, you find it comes to around 135. So this patient is having a normal sodium level. So you don't have to correct 119 with 3% NaCl, which is a common error, which is done in many of the ICUs. But it doesn't get better. Suppose this patient had a sodium of 130 and Rbs is around 900. Now watch. This has increased from 100 to 900. That means 9 times it is increased. So 9 into 2 is 18. So 130 plus 18 is equal to 148. This means that this patient is having hypernatremia. So to treat this patient in lines of dehydration because he is having a 148 milliequivalent body. So what may seem very alarming at 130, but when we correct at the correction factor, we find is 140 is high sodium. That means his patient is very hypernatremic. That means he is having dehydration. So these are the two things you must always remember in correcting sodium with regard to blood glucose. Thank you so much.